Okay, I'm gonna record this. Okay, perfect. Hi everyone. Welcome to our panel discussion on the unequal impacts of the opioid crisis. Thank you, Anne and Sam, for joining us. As you all know, we're NARCare, we're a student organization on campus. Our work is around spreading awareness about the opioid crisis and teaching students how to protect themselves and others. These are some of our goals. As you're all members, you should be familiar with this. And as far as today's event, it's in our second category of events where we do forums and storytelling. So we try to get people who are working on the opioid crisis in different ways to come talk to us so that we have broader understanding of the issue and not just what's out there in the media or what we kind of understand from just like perceptions. And so our first speaker, I know I said Anne was going first, but I guess Sam's going first. Our first speaker is Sam Quinones, who is a Los Angeles-based freelance journalist, a reporter for 37 years, and author of 4 acclaimed books of narrative nonfiction. Sam is a veteran reporter on immigration, gangs, drug trafficking, and the border. He is formerly a reporter with the LA Times, where he worked for 10 years. Before that, he made a living as a freelance writer residing in Mexico for a decade. His latest book, released in November 2021, is The Least of Us: True Tales of America and Hope in the Time of Fentanyl and Meth, which chronicles the emergence of a drug trafficking world producing massive supplies of dope, cheaper and deadlier than ever, marketed to the population of addicts created by the nation's opioid epidemic. As the backdrop to tales of Americans' quiet attempts to recover community through simple acts of helping the vulnerable. The Least of Us follows his landmark book, Dreamland: True Tale of America's Opiate Epidemic, which ignited awareness of the epidemic that has cost the United States hundreds of thousands of lives and become the deadliest drug scourge in the nation's history. Please join me in welcoming Sam.
We on?
Yeah, you should be able to see everyone now.
All right, great. Well, thank you, Cyril. Thanks to Anne as well. Good to be with you all. I guess the topic of today is the unequal effect of the opioid epidemic in rural America. I think also it's very important, and I'll talk a little bit about that. I'm going to talk a little bit also really about the most important issue I think that facing us now, which is fentanyl and methamphetamine, which are nationwide and creating problems that we never imagined before. Excuse me. I would say that when it comes to the opioid epidemic, understood as the period when doctors were prescribing really just excessive amounts of narcotic painkillers, largely pushed by pharmaceutical companies who made these painkillers, pushed also by major medical institutions like JCO, which authorizes accredits hospitals, and the VA, which is for veterans, of course. What you first began to see, the place where all this first began was in rural America, or the Rust Belt, also parts of Ohio, Tennessee, Indiana, Kentucky, West Virginia, places that had lost people as the great concentration of population really took place and people moved away from these areas to the cities. And also a lot of jobs died. A lot of jobs went to Mexico, went to China, went to various parts of the country. And you began to see that these places were the first hurt. One of the things you also began to see is that people were resorting to doctors for all kinds of pain, not just physical pain. Economic pain was part of what they were looking for too. And so doctors, frequently very well known because these are small communities, became kind of the place where they would resort when they needed, people to sign workers' comp pay because they were hurt, or because they wanted to pretend they were hurt. Sometimes this was not the case. And doctors were increasingly pushed to provide some kind of help. Early on, I think before this opioid thing began, a lot of people went for, my reporting in certain areas was that a lot of people went for diet pills. They were, just either trying to get high or lose weight or what have you. But as time went on, the pharmaceutical companies understood that there were certain doctors in certain areas. Data showed that there were certain doctors in certain areas, many of them rural or Rust Belt areas, that were already prescribing lots of drugs, largely because they didn't know what else to do. These were people who lost their work, jobs, the coal mines closed, factories closed, variety of things like that. And they just didn't know what else to do. And these are people that sometimes they'd even given birth to these people or birth these people with, and so on. And so they knew each other, these people, for years and years and years. They didn't know how to say no. And so, and along comes then this new kind of, this revolution really in opioid prescribing and the approach to the use of opioids. Before this, doctors were learned to be very reluctant to prescribe these kinds of pills because they're extraordinarily addictive. We learned that once again, but there was a time there when pain specialists and pharmaceutical companies began to argue, no, they're not addictive if you're in pain. If you're a pain patient, they're not addicted. Doesn't matter what your background is. You have drug problems in your background, your family does, none of that matters. It's just, there's this kind of blanket idea. And so what we began to see, particularly in rural areas, Rust Belt areas, is people come into these doctors who were very heavily marketed to by pharmaceutical companies because they had data that these doctors were already prescribing a lot of different kinds of drugs. These docs began to get visits, like monumental numbers of visits from companies like Purdue Pharma, which makes OxyContin, I guess it still does maybe. So what you began to get was these doctors who were already kind of feeling themselves under the gun and prescribing was already a habit. They began to get these visits from these doctors saying, we've got a new thing and they're opioids, and this is how you treat pain. Well, these were areas in nothing but pain. Physical, emotional, economic, social pain. And so as time went on, these areas were the places where this thing first took hold. And it was a hurricane, a devastating hurricane of pills that went through, and it didn't really stop. This is always, I mean, this story, both this story and the fentanyl and meth story, are really not about demand creating supply. It's about supply creating demand, in my opinion. And you begin to see enormous quantities of pills being prescribed, and then a lot of them leaking out. So people would get them prescribed, but a lot of those pills would make it out into the black market. Every area had their own black market. And they began to, it became kind of what replaced marijuana and beer at parties. And on athletic teams, people who had injuries were automatically, very quickly got addicted because they were given way too many of these pills, plus refills. Because remember, the idea was now these pills were known by science. It was not true, but they're supposedly known by science not to be addictive when used to treat pain. And so the first areas that really got blasted with this, and where a whole generation, or maybe two actually, was lost, were in rural areas. And the states that I mentioned earlier, Virginia is another one, Maine, lobster fishing was brutal work, and a lot of people got addicted to OxyContin because of lobster fishing. Rural areas of New Mexico, parts of Oklahoma, et cetera. You began to see these areas as the places that got hit first, because I believe pharmaceutical companies had data about doctors in those areas. Those doctors were already prescribing a lot of pills, all kinds of stuff. And wherever there's lots of prescribing, there's an assumption that those docs would be willing to prescribe more if they're hammered with relentless. This was a change also in pharmaceutical marketing. Pharmaceutical marketing to totally change. It used to be pharmaceutical salesmen, and they were almost all men, were old doctors, or retired pharmacists. They knew what they were selling because they'd been in their career, they'd been doing this, and they did not, at that time, they did not want to burn doctors or sell too heavily because they were part of the community. They'd grown up there. They were part of the community. They weren't moving on to some other new territory. And so what you had was doctors really truly grew to rely on pharmaceutical reps who were also had their behavior mitigated by the fact that they were part of the community and they did not want to lose that credibility. And then all that changed. Mid 1990s into the 2000s, I think the figure was we had 38,000 pharmaceutical sales reps in America in 1995. We had 102,000 by 2002, and none of these were people who knew what they were all young. A lot of them were women, very pretty. A lot of them most of them had no background in medicine or pharmacy. They all had background in sales. So they didn't know what they were selling, but they did know how to sell it. And one of the ways they mainly sold was just relentless visits, always in the face of the doctors, always giving away stuff, little stress balls or pens or pads, lunch all the time with lunch, because they knew that if you feed people, they automatically have kind of like feel you're a good person. And so once you control the staff as a sales rep, you control the doctor. And this was another part of it, particularly in these smallish towns where these guys would show up and then they would move on. They didn't really care about their own credibility because they knew they were moving on to another territory, these sales reps, in 9 months or a year and a half. No one's going to see them at the football games. No one's going to see them at church. That's very much unlike the pharmaceutical reps that had once dominated the industry. And so what you began to find was just widespread addiction, widespread death, widespread attempts to find treatment that kind of marched in step with the amount of pills that were prescribed nationwide beginning in 1996. 1996 is when OxyContin is released first time to the market. And at that year, it's like it's like for years, opioid prescribing was like this. In 96, it takes off like an airplane leaving the tarmac. And it doesn't really stop for another 15 years, actually more. And so that is really what happens with the opioid epidemic as we know it now, which is the process I just described to you of doctors overprescribing and so on. And many people and generations of people got caught up in it, had died or had their lives mangled, had their children's lives mangled because of this. All of that, I think it's important to talk about too, and then I'll leave it to Ann, and we can just take questions after that. All of that laid the groundwork for what we have today. The Mexican drug cartel world figured out as they began to, and this is part of my book Dreamland, right here. They began to supply new amounts, new enormous quantities of heroin to this market because people who were using pills very often lost their insurance, couldn't afford pills. Doctors cut them off. Finally, heroin and oxycodone and hydrocodone, these are chemical cousins. They're all opioids. They're all very similar in effect and withdrawals and all the rest. The Mexican trafficking world began to sell huge amounts of heroin. This was totally new. I lived in Mexico for 10 years. Nobody really wanted to be a heroin dealer in Mexico because it's a very scuzzy drug. Down in Mexico, it's viewed as like the lowest of low-class drugs until they figured out that there was this brand new market and it was all over the country. And so all of a sudden, you got a whole lot more people getting involved in it. Along the way, as they were doing that, they discover something what they called heroína sintética, synthetic heroin, was really fentanyl. That's what they first called it initially. 2006, if you read my book, The Least of Us, there's a whole set of stories about how the drug trafficking world in Mexico figured out that there was this thing that they no longer had to grow poppies. They no longer needed land or water or farmers or any of that sunlight. They just couldn't make it. This is synthetic drug. It made only from chemicals. And they figured this out. And as time went on, it's a long story. We probably don't have time to get into it all. If you'd like, it's all in the book, The Least of Us, that's right behind me. But what ends up happening is that the supplies are enormous, paralleled only by the supplies of pills that the doctors and pharmaceutical companies once unleashed on the country. Now you see that really begin to decline, although it's still a problem in a lot of areas. I wouldn't say it's over with. It's just become dwarfed by the other problem, which is now you get a similar enormous increase in synthetic drugs, primarily fentanyl and methamphetamine. And you are seeing this now on the streets all over Washington, all over the country. That's the remarkable thing, because they are really, you've never seen one underworld group, because it's not really an entity, it's more like a kind of confederation of traffickers, cover the entire country with even one drug, let alone two. But that's what's happened in the last several years. And these drugs are coming together. Used to be that we would have cycles, right? So you'd have stimulants, 10, 12 years of stimulants, then 15 years of depressants, and on like that. Cycles. Those cycles are over. This is like both of them are coming together and in the highest potency possible. Fentanyl is so potent. It's the most deadly drug out there. It's a wonderful drug. Got to keep in mind, fentanyl. I've had fentanyl in surgery. It's a magnificent drug when you use it surgically. On the street, it's an absolute catastrophe. Okay. Why is it great in surgery? Because it takes you in and out of anesthesia very quickly. With morphine, you're doped up for 4 or 5 hours. With fentanyl, I could attest you're kind of in and out of it, and then within a minute you're lucid again. It's a magnificent drug, fantastic. On the street, though, that very property is what makes it absolute torment for users. Addicts on the street have to use all the time because fentanyl is constantly leaving their opioid receptors. It's constantly being bumped, kind of. And so you have people never really able to live a life. They're always looking for fentanyl because they're always got these withdrawal symptoms right here, right? And of course, that makes it a wonderful drug if you're a drug dealer, right? Because you could just sell and sell and sell to these people. And if they die, well, there's more people being created. This is all about supply creating demand, in my opinion. Don't have time to go into a lot of why that is, but maybe during question and answer we can. What that means is, for those of you interested in Narcan, is that you now have a completely unique situation. I'm pretty sure that's true, that we have never seen people overdose so often in America. And we've never seen people, some subset of those people, revived so often. The problem, there's some problems with Narcan now. Believe me, I keep Narcan with me all the time. I have it in my backpack. I take it with me wherever I go. But the problem really is that when you rely only on Narcan, you have kind of convinced, it's very important. Narcan is extraordinarily important. That's why I keep it with me. However, it is only a Band-Aid. There is no, you cannot think of it as more than just a very, very temporary a solution. And the problem is that we have thought of it as the solution, or at least a de facto, that is the solution on the street, where you see people now overdosing and they have 20, 30, 40. I've met people who had 30 and 40 overdoses to their name. Never has that happened in the history of the United States. The problem is that all those people, the longer they're on the street, the higher risk they have of death. And the way we've used Narcan up to now is to say, well, we saved their lives. You know, you didn't save their lives. You temporarily kept them from dying. Very important, not a trivial thing. But all the people who are dying have had many, many overdoses, have been revived from many, many overdoses. The problem with the way we view Narcan today in the new fentanyl, the time of fentanyl and meth, is that Narcan can be kind of like a one-stop solution. And I have seen that idea in play, and it just is not a good idea. We need to have some place to put those people, take them off the street, or they're going to die. That is the new situation on the streets today. Meth will drive them mad, and fentanyl will kill them. And long before they ever develop readiness for treatment on the street. So we need to understand how things have changed. Narcan is an essential tool, very important to have around, as I do, but it is not a solution. It's really a temporary Band-Aid, and it needs to be understood as such, because what then needs to happen is we need to figure out ways of getting people off the street, sometimes against their will, because they are now being kind of dominated by these drugs that are unforgiving and will drive them to mental illness and eventually to death very, very quickly. So if we just rely on Narcan, we're just setting people up for that. And I think that's one of the main drivers of opioid overdose in America in the last few years, is that people are left on the street thinking, well, I saved their life. No. You temporarily kept them from dying, which is not a bad thing. It's a good thing. But keep in mind that person will die if we as a society don't find ways of pulling them off. And that is the new reality with widespread supplies of fentanyl and meth. I've already talked too long. I'm going to turn it over to Ann, and we can talk about questions later if you like.
Thank you, Sam. I was asked tonight to talk a bit about my time working on these issues in DC. And I'm going to talk a little bit about some of the activity that I led in my time serving at the Department of Agriculture and then at the White House in the Office of National Drug Control Policy. But I want to take a few minutes just to tell you a little bit about how I got there and how I began working on these issues. I don't know what brings you together as a group, what your purpose for being involved in this organization is, but knowing that you are beginning your careers, maybe some of what my journey has been will be helpful to you. I am from Indiana, and much of my career has been in agriculture. That's an industry that I grew up in. I got a law degree, and after law school, I went to work on Capitol Hill, and I did a lot in rural communities, but it was not, at best, it was healthcare related. I never dreamed when I graduated and went to the Hill that I would be working on substance use issues. Much of my career had been a mix in agriculture, in different state and federal roles. And all of that began to change in 2015. There's a county in Indiana, Scott County. It's a rural community in the southern part of our state. If you've ever been to Louisville, Kentucky, it's about 45 minutes to an hour north of Louisville. And that county made national headlines, international headlines in 2015. And the reason it made those headlines is because it experienced a massive HIV outbreak that was due to injection drug use. And a lot of those headlines were jarring, not so much because of the HIV and drugs. It was jarring and got a lot of attention because of where it was happening. This was not in big cities where a lot of people had come to think about these issues. And I had done a lot of work in that area and counties like it, both professionally in my ag job and then in volunteer ministry work that I would get involved in at my church. And that really caught my attention because I started reading the articles and thinking about the things I had seen in a lot of these places and really started to connect dots and think, yes, I can see how this could happen in a small town. And then 2016 came that next year, and one of the books that I had begun to hear a lot about online as I was reading about the Scott County situation was the book Dreamland, Sam's first book. And I have a very distinct memory. In July of 2016, I was on a mission trip in West Virginia. And this was a book that I ordered on Amazon. And I thought, oh, this will be a nice read during my time that I'm on this mission trip, which is kind of funny because I'm not really a reader. But I got that book and I couldn't stop reading it once I opened it. We would go and work on houses during the day, come back to the home base camp, and I would get away from everybody else because I wanted to keep reading that book. If you haven't read it, you need to. And it really, I saw Sam in my home state about a month ago and had an opportunity to tell him that that book really changed my life. It ignited a passion in me that I've really followed ever since. It was a very jarring read for me in that Sam does an amazing job of telling stories of people in communities and giving the facts as well as he collects, the information that we need to understand how we've gotten to where we are. But what was so jarring for me in reading it, why I think I couldn't put it down, is some of the places that he talked about were places in my home state. They were places in neighboring states where I had traveled and been. I could relate to a lot of the communities that were there. And I also couldn't get myself away from the timing. Some of the things that he talked about happening in my home state and in the neighboring states were happening at a time that I had been in leadership positions in Indiana government. I was in the know, if you will, of what was going on in sensitive issues like this, and I had no idea. And I'm confident that the leaders I was working for didn't know either, because we didn't do what could have been done about it. And I like to say, when you read Sam's book, and if you have spent time in these places, once you see it, you can't unsee it. And that really drove, I had to get involved in this issue. And in the fall of 2016, it was an election cycle, and a lot of congressional staff like myself will leave and go help in your home state or go and get involved in campaigns. And I decided to go home that fall and help on some local races. And so in my drive from Washington to Indiana, I deliberately drove through the town of Portsmouth, Ohio. And this is a centerpiece of Sam's book, Dreamland. And I spent a day in that town just by myself, driving around and going to some of the places that Sam talks about in the book. And I remember taking a walk before I left that night and walking along their river path. That town sits right on the Ohio River. And they have a mural that is painted on some of the flood wall that's there to protect the town. And I remember there are stars on this mural of famous people that have come from Portsmouth. And it was hard to look at that mural because you think of the kind of talent and people that have come from that community. And then you think about how it's been ravaged by the opioids and by addiction generally. And from that night, I really made a decision that if I ever had an opportunity to do something on this topic, if the door opened, I would walk through it. And that door did open. When the new administration began in 2017, I was pretty interested in leaving Capitol Hill, working on farm policy as I had, and I had a big job on the Hill. But I have to do something on this if I can. And as the new administration started being filled with appointees, I had an opportunity to go to USDA and work for the Secretary of Agriculture, and I was over the rural development mission area. So I oversaw broadband, rural healthcare facilities, a lot that relates to addiction in that it creates the conditions of the communities in which some of this takes hold, but it wasn't directly related. And then President Trump declared a public health emergency with the opioid epidemic. And he essentially turned to all of his cabinet members and said, if you have something to contribute to this issue in your department, you're going to put it on the table. And so Secretary Perdue asked me to really look at USDA and what we had that we could give as resources to help communities with this issue. There was an opioids cabinet that was established, and this was a group that met weekly at the White House, and I represented agriculture in those meetings. It really brought together kind of a wide breadth of agencies that had something to work on or contribute to this issue. The agencies you think about, like Health and Human Services and Department of Justice, but it also brought in some of the agencies you might not think about, like Interior. I know, being in Washington State, you have some amazing tribes out there that have jumped into this issue. Interior was involved because they do so much with the tribes. Treasury was involved in that group because a lot of modern drug trafficking is not happening in a back alley. It's happening through the mail, and there are digital transactions happening that we need somebody like Treasury to be on top of. During that time, a couple of interesting things happened with respect to rural. There was a real surge in overdose deaths in rural areas, and the CDC started to really pay attention to some of these numbers rivaled what we see in urban places. And in some cases, overdoses in rural were even surpassing what we were seeing in urban. So again, I think many people think of this as an issue that happens only in big cities, bad neighborhoods, and that's just not reality. The other thing that I saw during this time that was very special to me is that there was a real shift in rural views, if you will, in some of the stakeholders. You saw rural sheriffs starting to look at this issue differently. Agriculture, Farm Bureau is a major agricultural organization, and they really jumped into this, recognizing what was happening with some of their farm members or farm families who had lost children to the epidemic. Were finally breaking silence and talking about what was happening. So the organization began to get involved. The rural county officials, National Association of Counties, really jumped into this issue. And so you began to see this shift even in conservative communities, and we still have a long way to go, but this belief that maybe addiction is not just a moral failure, but it's a disease and we need to treat it as such. So some of the activity that I got really involved in, I did a lot of travel. I went to 47 states. And in some states, I used to think I was practically been there enough times to vote because they were places that had been so hard hit. Kentucky, Tennessee, West Virginia, I was there multiple times. But getting to see the issue from a place like Virginia or Indiana, where I'm from, and then seeing it in a place like Alaska or Washington State, Oregon, the Pacific Northwest, the issue looks very different in how it is addressed, but there are snippets that you see in communities that you can then share in other places that can be replicated. I convened a rural stakeholder or work group in DC. Some of those organizations I mentioned, the Farm Bureau, sheriffs, county officials, they all have associations and representatives that live in DC and represent them, day in and day out on the Hill and in the executive branch. And I would bring those stakeholders together monthly when I was at USDA, because they needed to know what we had to help with the issue, but perhaps more importantly, they needed to talk to each other because there was a lot that they could do together in their communities, but at an organization level, they wouldn't necessarily be talking. I held 5 opioid roundtables around the country. We did these with members of Congress, governors, an attorney general in Utah, did these with high-level folks, and those were designed really to help lift up the issue and give permission for people to talk about it in a rural setting, and then to draw out what the needs of these communities were, and then what some of the solutions were that could be replicated. The needs that I saw were very clear. There were kind of 3 buckets. communities were looking for data. They are looking for data. There's a lot of data out there, but most rural communities want to know what is going on in my county, not what's going on in the state or in an urban landscape that doesn't really translate to what they are looking at. People were looking for promising practices, things that were working that could be replicated. And then lastly, they're looking for resources and often grant funds. And so we tackled those three issues by creating a rural community toolbox. And that was really designed to give tools to local leaders that wanted to go and put solutions in place in their communities, because we knew this would be solved at the local level, not by DC. DC has money, states can impact where those dollars go and maybe some policy changes, but so much of what is truly going to change things happens at that community level. On data, we worked with the NORC Center for Healthcare Analysis. It used to be at the University of Chicago. Now it is at East Tennessee State. They have an amazing map that allows you to look at overdose deaths by county, look at trends and how that changes over time, and then overlay data about some of the social drivers that can often, especially in a rural area, impact what those overdose rates look like. Things like unemployment, disability rates, what education level folks are at. So that was really helping communities by putting data together in a comprehensive way. In the area of promising practices, we worked with a group of 12 other stakeholder partners at a national level to write a rural community action guide. And this included articles on several key issues that the stakeholder groups wrote, as well as a large appendix of promising practices for each of those topics. These were things like recovery housing, broadband, how to get a faith community involved in this issue at a local level. That was another important tool. And then lastly, I mentioned money. There's a ton of money out there to work with, but many people who need it the most don't know which agency to go to for what they're looking for. And so we put together a federal funding guide that was essentially a compilation of major federal funding sources that folks could go to depending on what they were looking for. That was very well received on the ground. But what was interesting to see in DC too is that these agencies often aren't talking to each other. And so making them come together in a work group to put that product together really had other benefits as well. One last thing I'll mention that we did, we also helped, we worked with Department of Justice to put together some workshops around the country with rural sheriffs and judges. And we found that those two roles in particular, depending on where they stand on the addiction issue, can either make or break a community. And we wanted to get folks who had really done innovative things around substance use, maybe interacting with others that are a little hesitant to do something different and to try something new, and to see if we can get some of that innovation spread between those two networks. Before we open it up for Q&A, I do want to mention just a couple of lessons that I learned in this work that as you're thinking about rural, I think are important to keep in mind. One, we often talk about all of the challenges that we see in rural communities. There's not enough resources. We got problems with broadband, transportation. Sam mentioned, the economies in these places, Rust Belt, they're often tough. But I think there's another side of rural that we miss when we focus just on the challenges, and that is really the assets that we have in a rural community. I live in a rural community right now. We see a problem, in a week, we can get everybody that needs to be together at the table and figure out a solution. Whereas, my Marion County, which is our capital county here in the state of Indiana, they'd take a year to find out the right people to get at the table. So I think the relationships that you have in rural and the ability to come together and work together as a community is just very different in rural versus urban. And I think that's a huge asset. Another thing that I'm really passionate about, and I learned firsthand in this work that I've described, is that what is going on upstream in a rural community really matters. We have so much money going in, understandably right now, into treatment, into setting up recovery infrastructure, so that people come out of treatment, can maintain that sobriety. We have spent a lot of money on enforcement, and all of that is needed. But if you go to any meeting, recovery meeting, and sit and listen to just a handful of testimonies, there are more times than not very common themes that emerge from people that have struggled with drugs. And so when I think about where we need to be investing dollars, I think getting upstream and seeing what's going on in some of these places is incredibly important. Prevention is hard to invest in because there's longer horizon for returns, and policymakers want to see, what did I get for those dollars I put in? But if we miss that point, we're going to be forever focused on how do we get people who are currently using to stop using, and that just becomes a cycle. It's the nature of addiction. And then the last thing I would say that I've learned is that capacity is so key to getting funds in the right places. Often the communities that need the resources the most don't have a grant writer. They don't even know where to go in terms of an agency, federally, state, or maybe even local. And so that capacity piece is something that we can't take our eyes off. Then one more comment I would make, I think, before we open it up, especially, when I think of where you are as students and thinking about where you may step in to make a difference in this issue. I am back home in Indiana, in my home state. I love it. I live in a rural community that is very special with respect to this issue. It's a very innovative place. We get regular visits from state leaders. Last fall, we hosted the White House current drug czar. People move to our town to get well and stay well because of the support that we have here from our local elected officials, our employer community, industry. We're a unique place in how people look at addiction. So I get to be part of really cool stuff every day. And I was thinking about tonight and how ironic it is I get to be on a panel with Sam, and thinking of my journey began with his book. I've done some really cool stuff in Washington, but there are days, and at a state level, but there are days when I look at what I get to do in my community. I'm in leadership here in our health coalition, so I'm kind of frontline, and we do a lot of the work that happens here out of our health coalition. And I'm just reminded that so much of this issue is just looking at where you are and what the need is, and recognizing that you can have an enormous impact on this in your own community. You don't have to go to Washington. You don't have to go to your state capital to make a difference. You just have to care and have the people skills to work with others really to see what's needed and to meet that need. So I really appreciate the opportunity to be here tonight. And I guess I'll turn it over back to you to ask any questions.
All right. Thank you so much. All right. And so we'll be taking some questions now. I'm just also going to pull up a QR code in case people want to. Oops. Okay. Do we have any questions? And if you want to ask anonymously, you can scan our QR code. Yeah.
So we mentioned that how much doctors prescribe, and also like the problems of who can be a pharmaceutical salesman play a big part in the opioid crisis. So it's like, is there any way that we can tackle this issue of, I don't know, regulating how much opioids can be like who can become a pharmaceutical salesman?
Well, I would say that, by the way, thank you, Anne, for your very kind and generous comments. It's really interesting to hear what you said. Because of what you were saying, I posted on the chat room, in the chat thing, a story that I wrote for the freepress.com about the town of Hazard, Kentucky. You can see it there if you guys go to the chat room. And it's really about the local efforts in a very small town, 5,000 people in Eastern Kentucky, where they have really, I think, done some fabulous things with regard to business creation. Many of them Many of the owners of these new businesses they're very, very small businesses, they're micro entrepreneurial kind of efforts. And many of the owners are in recovery from opioid addiction. Many of the workers are too. But now they have 47 new businesses in downtown Hazard and 171 new jobs, which sounds like a small amount, which is. On the other hand, for Hazard, it's huge, and it creates this whole synergy, this energy moving forward. People are tired of the negativity, the downer aspect of drugs. So if you want to read something that I had very much what Anne just said in mind when I was writing that this is really, the solutions come at the local level most effectively and most creatively, it seems to me. And that story is one. I'm hoping to write other pieces in a while. I'm finishing up another book, and so I got to get that done first. But with regard to salesmen, I think the excuse me, as far as I can tell, the pharmaceutical industry is huge, and it's varied and diverse and all this, because sometimes you get a lot of companies selling just one drug and this kind of thing. So it's hard to say. But I would say that by and large, there is absolutely no leeway anymore for salesmen to have the kind of access that they had for many years in the 90s and the early 2000s. Before, they could come on and walk the corridors of the hospitals. They cannot do that anymore. Before, they could offer lunch to an entire wing of a hospital or an entire doctor's office. That is really frowned upon now. There's a lot of things put in place that keep the most egregious violations or breaches of ethics from happening the way they did fairly routinely for a good number of years in the 90s, early 2000s, that helped to lead to all this kind of thing. But I would say that salesmen do not have that same. In fact, I was reading a story a while back, several years ago. It was called the era between 1995 and 2008 or 2005. I cannot remember anymore. The golden age of pharmaceutical sales, because anything went. You could do anything. You could say anything almost, and you had access, almost untrammeled access to all kinds of doctors. And now that access is way shut down, as it should be, and you cannot give gifts. You cannot. I mean, my understanding is that again, the industry is enormous. So I would say that a lot of what has happened to help create that whole problem that I wrote about in Dreamland is from a sales perspective, I don't believe is the case anymore. I would still say the pharmaceutical companies still view it in their interest to create illness problems and then provide the solution to those illness problems. I would say the ADHD has some hallmarks of that, and so but the egregious violations that you were seeing during the opioid epidemic, early days, like those early 10 years, maybe something like that, I don't think they are as easy to get away with anymore.
All right, thank you so much, Sam. Anne, would you like to answer the first question that's on the screen?
Sure. So the question is, how does being at the forefront help make a change, and what would you say actually works to make a difference? So a couple thoughts about what I've seen, and I'm going to talk about this, I think, from the community perspective, from communities I've seen both in the roles I've held and then being back home and in a community that could be a story like Hazard. I think first, recognizing, especially if somebody has been in active addiction for a while, that there are often many other needs that need to be met in addition to getting them to stop using substances. And so a lot of what I mentioned, that the health coalition in my town is really what drives a lot of the activity. It's kind of the hub. And that's a huge blessing, because we don't just help get somebody to treatment. we have care navigators that are helping figure out what's their housing going to look like when they come back out of treatment. Do they have primary care needs that have gone unmet? What's their job situation? Our men's recovery home, we have an innovative model, is built in our industrial park. That got us out of not in my backyard issues, but more importantly, when men hit a level of recovery that they're able to work, they can literally walk across the road to Frito-Lay, who is very open to hiring people that have come out of addiction and may even have some criminal justice past. So the jobs are there, the housing is there, the primary care is there. It's not enough just to get people to stop taking drugs and think that that sobriety is going to be sustained. Another thing I think is really important to make something work long-term is that community factor. People need relationship. This cannot be a journey alone. And for many, drugs you have what's happened to them, but their relationships physically, but their relationships are gone. They are in isolation, or the only people that are around them now are people that want to use drugs with them. So getting folks out of isolation and in community, healthy community, we spend a lot of time in my town focused on pro-social activity for that reason. And then the last thing I would say at a community level is what people at the top think about this issue matters. I talked about the judge, the sheriffs in my town. The ringleader for good response to substance use disorder is our mayor. There isn't a bigger cheerleader for half of the people in our recovery community than our mayor. And when you have that kind of attitude set at the top, people using a word like junkie would never happen in Clinton County, because people would look at you like, what the hell's wrong with you? And that is a blessing that I'm aware. And we need that in other places. So I think those three ingredients at a community level are important for making a difference.
All right, thank you so much. Since we're close to time, I'm gonna group some of these questions. Sam, I think if you could just address what you talked about, maybe like potentially getting people who are on the streets, forcing them into treatment, or
I think this is one of the things that we're finding is necessary too, because on the streets, people just die too quickly. There, with heroin, I knew people 30 years on the streets, 30 years using heroin. They didn't die nearly so easily and so abruptly, like you just had all of a sudden you're talking to them and then a day later they're dead. This was not really happening before. I do believe what we need is kind of what Ann is describing, which is a kind of a continuum of care, meaning a community-wide array of options and services for people who are struggling with this problem. I do believe that it requires us to begin arresting people for what were considered small amounts of drugs, because there is no such thing anymore. That little fentanyl pill, that looks like a Percocet with fentanyl in it, that is not analogous to a bag of marijuana 25 years ago. It's just not the same thing. This is an invitation to the most grinding addiction and very quick death. That's what that is. So I believe that we need to rethink jail. And in fact, in my book, The Least of Us, there's a whole set of chapters on this one county in Kentucky that has rethought jail, part of the jail anyway, pods within a larger jail that are all about recovery. You have to opt in, but first you get arrested. You get arrested, you detox, and those same people who are on the street saying, no, I don't need treatment because I'm so strung out, I cannot fathom being away from my fentanyl. Once they get detoxed, once they get some time for their brains to heal, all of a sudden they're like volunteering for the recovery pod, right? And the recovery pod is almost identical to what you would have in a treatment center on the outside, with one blessed benefit, and that is you cannot leave when the drug tells you that you must. And that is an invitation also to death. But then, so you can read about it in my thing, probably not time to talk about it right now. There's a lot of aspects to it within the jail. But the main thing is that the jail is then preparing you to leave. And on the outside, then again, it's a continuum of care, meaning you don't stop with release. It's There's all these nonprofits on the outside that do all kinds of, that offer all kinds of services. One of them, tattoo removal, for example, very important, my opinion. Recovery of driver's licenses, housing, sober living, that kind of thing, job placement, also probation fines and child custody issues. Those things are huge problems, and frequently people trip up and start using again over those. So you have an entire, and what this means is you've got the entire community, all the assets of the community are in some way or another brought to bear, but it begins with jail. It really does begin with jail, because if you don't do that, then people will, if you don't have a place to bring them, to get them off the street, away from this catastrophic supplies of fentanyl and methamphetamine, people, excuse me, people will die on the streets. That's what's happening in this country today. So forced treatment, that's not a correct term. What's happening is you take people off the street, they detox, their brain heals to a certain degree, and all of a sudden they are eager, raising their hand for treatment. Now on the street, they'll tell you no. Oh no, you're fine. You're being raped every third night. You're being beaten all the time. There's feces, there's lethal temperatures, et cetera, et cetera. You're not fine. That's a drugs talking. It's so clearly the case. I think we need to provide areas where people can go, where they can't leave during these crucial months. And then you develop a whole continuum of care on the outside, so that you can gradually transition them to life on the outside. Drug courts are a big part of this as well. All of this is made necessary, again, as I say, I think by the just god-awful relentless supplies of fentanyl and methamphetamine they were now seeing, like from Maine to LA, all over the country.
All right, thank you so much, Sam. I know we're at time, but I do want to ask like one quick question, kind of wrap up the couple of questions we've had. And I guess you could start, but I think we'd like to know what kind of caused you to worry, but also what gives you hope about the opioid crisis. Maybe talk about like some things that you hope get implemented soon, or some things that you think would be good to get implemented, but mostly like what gives you hope as we move on and address this crisis together.
What gives me hope is the evolution that I've gotten to see about attitudes at a community level towards this issue. And again, I live in a special place, and I know that I do. But I think that there is such a growing recognition, sadly, because in a lot of places, maybe that family that somebody never thought would have somebody get sucked into this loses a child. That's actually what kicked off a lot of the work in Clinton County before I moved here. But I think we've come a long way. We still have a long way to go, but I think attitudes and awareness of this issue as a disease and not a moral failure have come a long way. Where I think we need to spend time, when I think about this issue going forward, I hit on in the lessons I've learned about the importance of looking upstream at what's going on. Many of the individuals that I've interacted with and hear their testimonies, drugs are essentially, as Sam talked earlier, they're masking pain, and it's not necessarily a physical pain. There's a lot of other things that have happened in their life or are happening in the life of the community. And if we don't address that, I think we will just continue to be in a vicious cycle that will get even worse as the drugs get stronger and stronger from the cartel.
I would agree with that. I would say a lot of that is, the community aspect. By the way, I would say one thing just as a reporter to you, if you guys are involved, wanting to get involved in this kind of thing, most important thing for y'all to do is immerse yourself in it. By that, I mean interview, like a reporter would do, one person after another, endlessly. People in jail, people on the streets, cops, paramedics, ER nurses and docs, all that kind of stuff. It's once you do that, you will develop your own idea what reality is and your own idea what will work in your area. So I really strongly advise you to do that. I would agree with Ann on a lot of this. I think that we have come, when I wrote Dreamland, nobody knew how to pronounce naloxone. Well, President Obama didn't know how to pronounce it. Okay, in a public forum, he just couldn't blew it, When there was no, I put opiate rather in the subtitle of my book, The True Tale of America's Opiate Epidemic, because nobody knew what an opioid was. If you weren't in medicine, you had no idea what an opioid was. There were three. When I wrote my book, when I turned my book in, there were 3 lawsuits against drug companies, and all 3 of them were on hold. They're in different counties around the country. And now and then by 2018, something like that, 3 years after the book came out, I can't remember what it was 2018 or 19, it was 3,000 lawsuits within like a 3 or 4 year period. It's just dramatic. It was an amazing thing. But all of this creates kind of like this awareness, this community idea that I think is so important. And the more we rebuild community in this country, which is the shredding of which was really at the root of all this. We didn't get a chance to talk about it too much because it's just not enough time. But community shredding is what is really at the basis of all this. And you see this no place worse than in rural America. Just horrible. I think that that is anything we do that promotes that, I think is a good idea. And finally, one thing that I know Dreamland is about a swimming pool in a small town called Portsmouth, Ohio. But I have this idea. If I were president, I would set up a fund, a private public partnership and endowment to help small towns, neighborhoods, neglected neighborhoods, and small towns all across the country, many in rural America, support and maintain and repair their swimming pools. Swimming pools are essential community. They're like plazas. They're places of people to meet. They're healthy, get you away from screens, get you outdoors. You learn a very important skill, swimming, among other things that you could learn. And the story of Portsmouth was the story of what happens when you lose your swimming pool, leaves you complete. What's part of a larger story of Rust Belt phenomenon, but you are torn apart. And you lose your swimming pool, you lose what brings you together. And after that, the only place where people really had to see each other was at Walmart after the Dreamland pool closed. And so my feeling is very strongly that one thing that would be extraordinarily helpful, would have ripple effects throughout every town and every county, is to provide funds so that small towns, neglected neighborhoods and small towns have some access to funds that help them do some major improvement, some major repair, because running a pool is so expensive for a small town. It is so expensive. And so that is one thing that I so far have not heard one presidential candidate mention that, but I think it's an idea that we need to work on.
All right. Thank you so much, Sam and Ann. On behalf of NARCare, I just say thank you for your time and all the work that you do. I think we all learned a lot. Yeah, thank you so much.
You're welcome. Thanks a lot, Ann.
Thank you. Good to see
you guys.
everybody.
Bye-bye.
All right. Good night. And then super quick, these are just our next upcoming events. We're gonna have a walk around this Saturday. We're gonna meet at the George Washington statue at 11 a.m. and we're gonna just distribute Narcan around the Ave and U District in general. And it'll probably be like 2 hours until 1, and then you might grab lunch, and boba. And then we're doing like a ooky spooky Halloween tabling candy Narcan distribution thing. That's gonna be 10 a.m. to 2 p.m. Obviously you don't have to do anything for that. You just have to come by, you can hang out. Should be chill. And then the week of November 11th, we're hoping to do like a Narcan training, similar to what we did last time. Just teach you how to recognize and prevent overdoses. And then November 22nd, we're giving a guest lecture for the Department of Anthropology. That'll be on Zoom. We'll share the Zoom link to our like email list in our Instagram. And then we have Thanksgiving and Dead Week. Probably during Dead Week, we're gonna do something chill, something fun. Probably like bring your computer, study, and I don't know, do something slime making potentially. And then we have winter quarter, which is kind of crazy, but I'm sure all of you are on our socials. But thank you so much for coming. Yeah, I know it's late. Get home safe and see you at our next event.
Are you gonna email us events happening?
Yeah, I will.